In this video, we are viewing the left glenohumeral joint of a patient in the lateral decubitus position through a posterior portal. An anterior-superior working portal has been established and diagnostic arthroscopy was performed. An arthroscopic probe is used to confirm and evaluate the extent of the slap lesion that was suspected based upon this patient's preoperative examination and imaging. A 4.5 mm arthroscopic shaver is used to debride any degenerative labral tissue, as well as lightly decorticate the glenoid rim in preparation for the repair. Working from posterior to anterior, a crescent-shaped suture passer is used to pass a PDS suture through the labrum. Compared to traditional repair techniques, the PDS suture is passed through the middle of the labrum to allow the horizontal mattress configuration to better restore the normal anatomy of the superior labrum. The PDS is then used to shuttle a 1.5 mm labral tape suture through the labrum from inferior to superior. A knot pusher may be used to aid in the shuttling of the labral tape suture to minimize any iatrogenic labral damage due to the thickness of the labral tissue or the acute angle of passage. A second pass with the suture passer is then made. The superior limb of the labral tape is shuttled through the labrum from superior to inferior to create a horizontal mattress configuration. This technique may be repeated as needed depending on the size of the tear. A percutaneous trans-rotator cuff portal is then created for the purposes of anchor placement and suture management. In this case, the sutures from the first horizontal mattress are retrieved through the trans-rotator cuff portal, and the previous steps are repeated to place a second horizontal mattress suture. In preparation for suture anchor placement, all sutures are retrieved through the anterior superior portal. Again, working from posterior to anterior, a site for the most posterior anchor is selected and an offset drill guide is then inserted through the trans-rotator cuff portal. A hard bone drill is then used to create an appropriately sized hole for the knotless anchor. The corresponding labral tape suture is retrieved and passed through the eyelet of a knotless anchor. The anchor is then inserted into the joint, the repair construct is tensioned, and the anchor is mounted into the drill hole until it is completely seated. The free ends of the labral tape are then cut flush with the chondral surface to avoid any chondral abrasions or suture irritation. Construct stability is confirmed with an arthroscopic probe, and the process of anchor placement is repeated for the remaining mattress suture. Once all anchors have been placed, the final repair is visually inspected and construct stability is mechanically evaluated with an arthroscopic probe.